Every patient has a story, and making sense of it is part of the healing. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue. Today, we pick up with Margaret Chisolm on how to assess behavioural addictions, how to talk to patients about their temperament, and how to appreciate the meanings they've made of their life story.
Life story perspective is all about the meaning somebody gives to events. So asking about how somebody's dealing with this event, how they understand this event, how they explain it. You know, if they've had a tragic loss of a family member, are they feeling guilty about it, like they did something wrong, it's their fault? Do they have a religious story that they're telling themselves that, you know, God is angry at them or punishing them, those sorts of things. So it all eventually comes out, if not at the first interview, over time as people share more and more of their stories.
So the life story naturally includes psychosocial external stressors along the timeline of your life.
Exactly. Each of these perspectives has a conceptual triad. I've alluded to a couple of the other ones, but the life story perspective triad is setting, sequence, and outcome. So it's just like any narrative. I often use the example of Star Wars, right? A long time ago in a galaxy far, far away, right? So everybody has these events that occur in a particular setting, in a particular sequence, and the outcome really is the story that they tell themselves about the events. So, you know, somebody might have an infant die of SIDS, and then the story they tell themselves could be that, you know, it was their fault. They weren't attentive enough, or they were co-sleeping with the baby. Or one of the goals of helping someone whose problem is best understood from the life story perspective is helping them re-script their story collaboratively. You know, well, maybe there are other ways of looking at this. Could this be a random act of tragedy? You know, how are you going to make meaning of this, regardless of why it happened?
The events are fundamental, but the meaning is the really critical part in the life story.
You know, the life story perspective is all about meaning, you know, meaningful explanations, which may not be causal. Sometimes people come with severe depression and give meaningful explanations to why they're depressed. Oh, I'm depressed because, you know, my wife left me. Well, maybe, but maybe your wife left you because you were depressed, right? Sometimes they sound good, but they're not really causal. You have to take those with a grain of salt, obviously, especially if somebody might be having a syndrome of depression.
Thinking from the perspective of, again, a 30-minute practitioner who's trying to help people, are there exercises or assignments you find particularly useful in helping to shake up the story and get people to rewrite their story?
Things that I do are to be very tentative about any interpretation that I'm offering and to be very collaborative. I try to remain neutral. I think it's like any skilled psychotherapist. You know, this sounds like it could be perhaps maybe using conditional language, I think is key there, and remaining neutral. I don't like to impose. You know, you're in a lot of power as a psychotherapist, psychiatrist. I really don't like to impose a story on someone. I'd like to be collaborative about it because so many people will agree with the story you tell them and you suggest, and it may not be really helpful.
I was thinking more if you're seeing them every couple of weeks, if there are helpful things you might advise them to do, not to tell them what the meaning is, but to help them discover the meaning on their own, you know, outside assignments. Like I saw in your book, you had them write down their story, or I thought of, it sounds like this is a place where the arts or creative work might come to aid.
Oh, certainly. I mean, for many patients, writing in a journal, keep reflecting on, you know, what happened to them if it's a life story event and the meaning they're making of it is immensely helpful. So I don't typically assign homework assignments. I typically do most of the work in the session, but that's just me. But I do think certainly reflecting on that. And I like to have people, if they are going to reflect in writing. on that. And they can certainly bring it to the next visit. But typically, because I'm not there as the therapist for people reading the book, I have developed these exercises, but I typically don't use much homework assignments, mainly because they don't do them. So.
They don't do them? Okay. Now, that's a great point. And you want it to be a success. You don't want to have guilt play.
No, they don't need another failure.
Yeah. Okay. And you implied that the behavioral piece is self-evident in the interview, but I'm not so sure. Like, I'm thinking, would I ask them, do you have habits that are hard to break? Like, what are some questions you would go to get at that part?
For eating disorders, for instance, I might ask, what do they imagine an ideal weight would be for them? And depending on their height, if they say, 100 pounds, it might be a concern. So asking questions about that, obviously asking all the substance use questions, how they drink, when they drink, what role drinking plays in their life, for instance. Another motivated behavior is obviously there's sexual behaviors. We ask about if they have, what the objects of their sex fantasies are, what their sex drive is like, those kinds of things. They use pornography, what type of pornography they use. And another motivated behavior is self-harm. Sometimes people, as we know, can be conditioned into harming themselves, with cutting, anxiety relief, or with suicide attempts because of the attention that people get with the attempt and coming into the hospital and all that. So people can develop habits that aren't really necessarily best explained by disease or a broken part, but because of conditioned learning.
Oh, I think I'm picturing it more clearly now, that rather than a blank, open-ended question, it sounds like you are going to assess for self-harm, eating behaviors, sexual behaviors. Are there others you put on that list that you would assess for at every intake?
Yeah, so I divide the behaviors into innate and acquired drives. So the innate drives are the things that we all do to either perpetuate our own life or the life of the species. So that's eating, sex, sleeping. So I'll ask about sleep as well.
So you're saying a lot of sleep disorders, not all certainly, but a lot of them would be behavioral.
I do want to know what people do when they wake up in the night and whether or not they're staying in the bed wide awake, which, from CBTI, we know isn't helpful to, you should only use the bed for sleeping and sex. And otherwise you should, if you're awake in the night, move to another place, because otherwise you come to associate the bed being wide awake.
So it sounds like you're going to assess for problems in sleep and do a fairly rich behavioral history around those problems.
Exactly. And then there's the acquired drives, which have hijacked our innate drives, neurocircuitry. There's not an innate drive to use heroin, but we can be reinforced through these circuits, especially if we have particularly either environmental or hereditary differences. So asking about drugs, asking about eating, those are probably alcohol. Those are the big areas, self-harm. Usually the acquired drive of suicide attempts is very obvious in the taking of the history, so it doesn't have to be a separate question.
Are you starting to have to deal increasingly with digital addictions?
Yeah, that's a really interesting question, Chris. It's, obviously this is a controversial field as to what is an addiction and what isn't an addiction. But I do think if you think about choice, drive, and conditioned learning, a lot of video games and social media, is designed to be highly reinforcing. So there's huge positive reinforcers that come with anticipating that next like, that it's intermittent reinforcement. It's the most positively reinforcing kind of reinforcement schedule. Did I get a like? And so there is that element of conditioned learning. And then, that increases our drive, and then that narrows our choice to resist. So if you think about it from the behavior perspective, it certainly is plausible that video game addiction or social media addiction could be viewed as a behavioral disorder.
Particularly during quarantine, more patients have become bothered by this addiction.
Yeah, that's an interesting point. Patients sometimes volunteer that. I haven't usually routinely asked unless obviously that's part of the chief complaint, somebody bringing in their spouse because they're spending all day on Facebook or.
One thing we struggle with as psychiatrists is patients often have the view that all of their problems are meant to be treated with medications. Obviously, sleep meds are a great example. Do you find that this perspective is helping you shift out of that pigeonhole with patients and to redirect them in other directions?
Definitely. I think it expands. I mean, it's an education process with patients, just like it's an education process with clinicians to start thinking of these illnesses more broadly or these problems more broadly. And so I think it does help patients to understand why a pill might not solve this problem. Because if I have a discussion about how I understand this problem is really arising more from something that they've encountered and the story that they're telling themselves about that, how they're dealing with that isn't going to be helped by a pill. A pill's not going to make that go away. The great thing about the dimensional perspective is that unlike the use of categorical personality disorders, it's not name calling, right? We're looking at somebody's strengths and we're saying, you're somebody with 2 more scoops of feeling than the average person. That doesn't mean that that's a bad thing. That's who you are. And it's great for certain situations because the conceptual triad for the dimensional perspective is potential, provocation, and response. Your potential in terms of your affective temperament is to have 2 scoops of feeling. My words for high on neuroticism, which, is really great because it's going to make you more sensitive. Artists, performers, they can really tap into that emotion and that high feeling state, those strongly felt emotions, which is great. Works for you great in those situations, not so good in some other situations. So you're not going to be able to change who you are as a person. This is core to your personality, but you are going to be able to change how you respond to that feeling, how you think, and how you act. So we're going to celebrate who you are. I'm going to try to guide you through life's provocations and together develop other ways of thinking and acting in response to those unavoidable provocations, like waiting in a bank line, or I don't know if people do that anymore, but waiting in line, driving in traffic, pretty much unavoidable and evokes strong feelings often. So we're not going to be able to avoid certain things, but there may be some provocations we can avoid. And so kind of figuring that out together. So I think it's just much more affirming of someone rather than labeling them as having a personality disorder, showing them that, there's a continuum, the spectrum of affective temperament from somebody who doesn't feel anything at all to somebody who feels things really strongly. They're here, and that works great in some circumstances, doesn't work so great in other circumstances. So people usually respond really well to that kind of frame, and that's not going to be helped with a pill.
You gave these really wonderful, specific questions that brought out temperamental features like neuroticism. And I really like that because I can see that those are things that happen in those people's lives a lot. And do you also have questions that bring out the strengths of some of those temperaments?
I'll say, are you somebody who is, if you notice some problem that you have, like something looks different on your skin, or you have a bump that could be, serious, are you somebody that goes to, seek professional opinion about that? Because if your feelings are too weak, you might ignore certain very serious situations because you're not worried about them, whatever. It'll all work out. These are the people that come to treatment literally with, grapefruit-sized tumors. I once saw a woman who, when I was an intern, who had a huge tumor growing out of her head. She'd covered in a scarf. Like, who goes that without seeking treatment? Well, somebody who doesn't worry very much. I like to frame it as a neutral way, every one of these dimensions, so that people can see that it's good in certain situations, it's not so good in other situations.
Let's pause for a preview of the CME quiz for this episode. Earn CME for each episode through the link in the show notes. In Dr. Chisom's approach, what is the most important aspect of the life story perspective? A. The meaning it holds for the patient. B. The relationship of life events to new episodes. C. The social determinants of health it reveals. D. The life story can reveal clues of a personality disorder. Margaret Chisolm is a professor of psychiatry at Johns Hopkins University. She has authored over 150 scientific papers and 2 books that explore the perspectives of psychiatry. One for professionals, Systematic Psychiatric Evaluation, and one for patients, From Survive to Thrive, Living Your Best Life with Mental Illness. Did you know that the FDA recently reclassified ECT devices and updated their indication? Read all about it in the February issue of the Carlat Report, where Vaughn McCall compares ECT to ketamine and TMS, and Stephen Hamilton looks at how long you can safely keep esketamine going. Subscribe online and get $30 off with the promo code podcast. Yeah, you have to subscribe for this content because we won't accept any industry funding.
Thanks for watching. Hit subscribe if you enjoyed this content. And to earn CMEs for listening, head on over to thecarlatreport.com/podcast.